everybody, happy Valentine's Day. This week for the channel, we are going to do something completely different. I just finished a bunch of continuing education credits for my license, and one of those lectures was on sleep apnea and mouth breathing. Now, I just posted 2 other videos about that, and there were some questions still from people, and a lot of those I'm not really qualified to answer. So what I've done is I recorded one of the CE programs, and I'm bringing it to you. And this is by Trish O'Hare. She's the woman who she's a dental hygienist. She has, I think, a couple other degrees, which they will go through at the very beginning here. And she is the one that I took the original lecture from 3 years ago. That just blew my mind and got me, on this stuff with my husband and getting his mouth taped shut. And so I'm gonna let her teach you guys everything that I know, which is from her. So I'm going to also link all of her stuff below in the description box. She's got a really great book called Lip Zip. She's got she calls it O'Hare University. There's a lot of really good information from her. So if you're more interested in this topic, even after this very long lecture she gives, go there and please check out her stuff. It's just phenomenal. This woman is a genius. So again, check that out below. Today's lecture is brought to you by Trish O'Hare, and please enjoy. It's a little long, but it's really, really good.
It is my honor to introduce Miss Tricia O'Hare. Miss O'Hare has practiced dental hygiene for 5 decades and has held faculty positions at the universities of Minnesota, Washington, Arizona, and Louisville. With colleagues, Tricia created O'Hare University for hygienists to complete their BS degree in 6 months. I am going to turn it over to you. Look forward to your presentation, Tricia.
Thank you, Carrie. It's a pleasure to be here, and I welcome all of you who are in the audience. I'm sure many of you have had a busy day already working, so welcome, and let's have some fun with the next hour and a half looking at sleep apnea. We're going to look at how to identify patients in your practice, not necessarily the ones who have sleep apnea, but the ones who may be on the road to sleep apnea, and what we can do in a dental practice, primarily as hygienists, to help these patients get off the track to sleep apnea. As we start, I want to introduce you to Nathan. Nathan in this picture is 7 years old, and you can see he's had Down syndrome, a few other issues, but a darling little boy. But when he was about a year old, he had a seizure, and for whatever reason, he hasn't been able to sleep through the night for the last 6 years, which means mom hasn't been sleeping through the night, or dad, for the past 6 years. Nathan doesn't seem to be growing, and when mom took him to the physician said at age 2, I know exactly what to do. We'll just put him in the hospital, put your darling 2-year-old under general anesthesia and take out his adenoids. Well, they did that, but nothing ever changed. At age 5, it was still a big problem, and the physician said, now this time I know for sure we'll just put him under general anesthesia again and take out his tonsils. But again, nothing ever changed. Nathan's grandfather, a little bit of history, died at age 49, and he had undiagnosed sleep apnea. The family was told that the grandpa, for whatever reason, gasping for air during sleep was due to GERD or a hiatal hernia. No one diagnosed sleep apnea. Well, now at age 7, mom has taken him again to the physician, and the physician has said, Nathan is simply failing to thrive, and there is nothing more we can do. Can you imagine being Nathan's mom and hearing that? Well, she is a hygienist, and she never gave up hope. She came to one of my courses in Seattle and listened to what I had to say and how, as a hygienist, she could intervene and make changes with Nathan. And in 5 days, Nathan was sleeping through the night for the first time in 6 years. So you too will be able to take this information today and use it with family members as well as patients. And here is Nathan the next year and the year after. You can see a big change in the look, the face, and the energy level. So let's look at what happened to Nathan as well as what will happen for you with your patients. With this information today, we're going to look at basic physiology of breathing just to get a little bit of breathing 101. We'll look at some of the habits that will lead to sleep apnea and simple steps that your patient can take to help. What we unfortunately see in marketing is that people are, especially female models, are told to lick their lips and open their mouth when they're having photographs taken. And even most models, as you look at them and see their photographs, you're going to notice many of them have their mouths open. Even on the cover of Vogue magazine, many of the models have their mouths open. So they're sending a message that open mouth posture is sexy. I don't know why they think two little rabbit teeth with an open mouth is sexy, but this is what a real mouth breather looks like, and it isn't very sexy. So I want to apologize in advance. You're going to notice mouth breathers everywhere now after this class, and it's a good thing, but it will drive you crazy because you will see them all. For most of you, it's going to be about your patients, but for some of you, it will also be about family members who are mouth breathers. So is anyone in your family a mouth breather? This is my family, and I was a mouth breather. Didn't realize it, but at one point, many years ago, I had a really bad case of bronchitis and was out of work, homesick. And at the end of that bout, when I got better, for some reason, I always had to have a glass of water by my bed. And I would wake up with a dry mouth. And I never put together that it was mouth breathing. I blamed it on the mattress, went through different mattresses, the Sleep Number, the memory foam, nothing ever worked. I tossed and turned every night, woke up tired at 4 p.m. I needed chocolate to keep going, but never realized until I studied myofunctional therapy and Buteyko breathing that I was a mouth breather. So it took me 3 months of exercises to get my tongue back up to the roof of my mouth where it belongs and to actually sleep through the night without breathing through my mouth. But the real poster boy for mouth breathing is my older brother, Tim, who also thought he was Elvis. And he has the classic signs of a mouth breather with the open mouth, those flaccid lips, a shorter upper lip, shiners always under the eyes, flat under the eyes. And if you look closely, you can see the whites under his eyes. What that means is that the sinus never grew forward as much as it should, and the tissue is just being pulled down around the orbits. The mouth grows narrow and with a high vault, but not forward because the tongue isn't in the roof of the mouth. Also, his slouch posture, he snored ever since he was a kid, had gingivitis and a crossbite. So all classic signs of a mouth breather. Healthy breathing should really be invisible and silent from the time we're born until we die, and in between making sure we keep our mouth closed and breathe through our nose. And that normal breathing should be very gentle, about 8 to 10 breaths a minute, not 20 as medicine often seems to think. Always breathing in and out through the nose, not in through the nose and out through the mouth, but always in and out through the nose. And one breath about every 6 seconds. And no shoulder movement, no chest movement. It should all be from the belly, moving the diaphragm, which then moves all of the internal organs. And we're finding with COVID now, many of the people having the most problems are mouth breathing just in the upper part of their chest. They're not actually moving their heart or their lungs or their digestive system. Humans are meant to nose breathe. The only time the mouth really should be open is when we're talking, when we're smiling, biting into food, but never chewing, swimming, kissing, oral hygiene. So the message really is lips together, teeth apart, tongue up. And that's where we want our patients. And check for yourself right now that your lips are together, teeth are apart, and your tongue is up. Now, mouth breathing isn't a new problem. Back in 1922, in this ad in a New York paper called Physical Culture, they were showing people how to stop mouth breathing and selling them a $2 chin strap. And in 1930, another advertisement from the Perfect Breather Company pointed out that snoring causes many diseases and often an early death. an early grave. And what happens here is what we now know. Those people were suffering from sleep apnea. The tongue would fall into the throat would collapse, and it would actually block the airway, and the pressure and the stress on the heart would lead to a heart attack. So they died not of not breathing, but from the stress on the heart. So as we look at obstructive sleep apnea, there are a lot of symptoms: early morning headaches, loud persistent snoring, daytime sleepiness, poor concentration, that irritability of the drivers who are unhappy out there, sometimes falling asleep during routine activities, that the frequent visits to the bathroom, generally at 4 a.m, restless sleep, and those are at plus choking or gasping for air, and witness pauses in breathing. And if you've ever slept next to someone who has sleep apnea, as they stop breathing, it's very nerve-wracking because you really want them to take that next breath. And if you've been in that situation, you tend to shake them to make sure they take the next breath. So all of these are signs and symptoms of obstructive sleep apnea. But what's surprising is all but 2 are also symptoms of mouth breathing. The witness pauses in breathing and the choking or gasping for air are not part of the symptoms of mouth breathing, but all the other symptoms that you see are. So we have quite a few predictive symptoms that can lead to sleep apnea unless they're addressed early. So addressing the mouth breathing is critical to prevent the sleep apnea. With sleep apnea, the airway will close mechanically by more than 50%. And you'll notice here the position of the tongue. So in the left picture, you'll see the tongue up to the roof of the mouth closed. And with the tongue up, the airway is open, so the person can breathe through their nose. And on the right, you'll see the picture of obstructive sleep apnea. When the mouth is open, the tongue very easily falls to the back of the throat and partially or completely blocks the airway. Now, with mouth breathing, how this happens is the air hits the back of the throat, and that air dries out the tissue, drying up the saliva, leading to that dry mouth in the morning. The tissue itself loses elasticity, and that throat tissue can collapse very easily. So let's look now, looking at the sleep apnea. Now, let's jump into the physiology of breathing to see, backing up, what steps lead us to this point. Why do we breathe? To deliver oxygen and to remove excess carbon dioxide. And we breathe in carbon dioxide and we also breathe it out. Something else that's interesting, another source of carbon dioxide, comes from the metabolism of carbohydrates. And when we metabolize carbohydrates, especially refined carbohydrates, there is a release of carbon dioxide that needs to then travel from the digestive system through the blood to the lungs and then be exhaled through the lungs. But with a diet high in refined carbohydrates, there's more carbon dioxide to exhale, and that can lead to overbreathing and to mouth breathing. And we'll look more at that as we go along. So how do we breathe? Always in and out through the nose, always belly breathing, and no chest movement. So you can put your hand on your chest as you breathe, and make sure as you're breathing in and out through your nose that your chest is not moving and your shoulders are not going up. And I know you've seen some of your patients in the chair breathing, and they're, and you can hear them breathe and you can see them breathe, and that's very unhealthy breathing. So you're sitting there now just breathing normally, not thinking about it. Subconsciously, it's going to tell you when to take the next breath. And that determination is made chemically. And it's made by a change in the pH in the blood. And that change in pH will tell you when to take the next breath. So more oxygen is actually absorbed on the exhale because the nostrils are smaller than the mouth, and the air will be released slower. The lungs, there will be back pressure in the lungs to exhale slowly. So as we're exhaling slowly, it gives more time for the lungs to transfer oxygen to the blood. Whereas if we're breathing through our mouth, it goes in fast and it comes out fast. But through the nose, it slows it down, giving more time for oxygen to be absorbed. The role of oxygen we know, but also there's a role for the carbon dioxide. And it is critical to release oxygen from the hemoglobin. And as I mentioned, it will trigger when you should take the next breath. And the CO2 does this by balancing the pH of the blood. Another thing that CO2 is important for is to prevent smooth muscle spasms. So if you're a runner, exerciser, and if you ever experienced those side stitches, a cramp in your leg, in your stomach, in your side, often that is the result of mouth breathing by exhaling the CO2 too quickly, not keeping it in the body long enough to prevent smooth muscle spasms. And I've worked with some athletes, and getting them to close their mouth while they exercise completely eliminates those muscle spasms. So looking now at oxygen absorption, this is the real critical aspect of nasal breathing. When you breathe through your nostrils, through the sinuses are going to produce nitric oxide, not to be confused with nitrous oxide, but nitric oxide. And this will increase oxygen absorption efficiency. So it will increase it by almost 10 to 18%. So the nitric oxide does many things. It's a bronchodilator, it's an antibacterial agent, vasodilator, and increasing oxygen absorption. But when we breathe through the mouth, all of this is bypassed and less oxygen is actually absorbed. So increasing the oxygen by 10 to 18% will lead to some very important advantages. People will actually sleep in a more regenerative level with that much more oxygen reaching the brain. Important, especially for children, is the release of human growth hormone. And what happens for people getting that regenerative sleep, it increases their stamina and endurance, and they wake up much more rested and refreshed. Surprisingly, nasal breathing will cause nasal congestion. People will tell me, well, I can't breathe through my nose because I'm congested. But what has happened is mouth breathing actually caused the congestion. It sends the wrong message to the brain. We have two respiratory centers in the brain. One will know differences between mouth and nose breathing. The other one is measuring primarily CO2 exhale. And if the CO2 is being exhaled too quickly, as in mouth breathing, the brain, the message it sends is that, oh, this person's breathing too much out of their nose. So let's plug up the nose a little, slow it down, constrict the blood vessels. So that's what these goblet cells do, triggered by the brain. So mouth breathing triggers the brain to produce more mucus, and that's what then causes more congestion. So we've had a quick overview of breathing 101, and we'll see that nose breathing is going to bring that ideal exchange of carbon dioxide and oxygen. It's going to balance the pH of the blood, slowing down the breathing and not pushing someone to take a breath too soon. And nose breathing is going to produce the nitric oxide, which increases oxygen levels, increases oxygen absorption. And on the other hand, lots of bad things happen with mouth breathing, exhaling CO2 too quickly, decreasing oxygen absorption, and leading to a drop in the pH of the blood, which then leads to taking the next breath too soon. So looking at that now, we've looked at just a bit about the physiology of breathing. Let's recognize now some of the habits people may have or conditions that lead to sleep apnea. And the number one bad habit leading to sleep apnea is mouth breathing. So let's take a look at that. When I was in hygiene school a long time ago, we were taught that mouth breathing only caused anterior gingivitis, and that it was important to put Vaseline on the tissue, and that would then help prevent the gingivitis. But so many more things can go wrong with mouth breathing, and you can see here a long list of problems associated with mouth breathing. And let's take a look just at a few of these. The poor little boy on the right has the look of the long-faced syndrome. So there are sleep problems, ADHD problems, infected tonsils, snoring, and a narrow palate. We'll just take a look at these from that long list. This is Dr. Stephen Sheldon, who is at the largest sleep apnea clinic in the US in Chicago at Northwestern University. And he has said there is no such thing as ADHD. These kids are simply sleep deprived, and sleep deprivation has the same symptoms as ADHD. These kids are simply trying to keep themselves awake. They can't pay attention in school. They're tired, irritable. They're often considered to have behavior problems because they keep getting up and down, not sitting still during class. And it doesn't really lead to poor brain development, but brain fog. And they tend not to remember things when they've been told. So ADHD behavior and this sleep disturbances associated with mouth breathing are linked to what Dr. Sheldon calls awake sleeping. And this is where the brain goes to sleep for fractions of a second while the child is awake. And while that's happening, because the brain is so tired, it needs at least a little sleep, there's no memory of what just happened. And this has happened to you as well, I'm sure. If you've ever been reading a book and it's a great book, you want to read a couple more pages, finish the chapter, and you read an entire page and you can't remember anything you read. So you read the entire page over again, and again, you can't remember what you just read. Your brain was going to sleep in fractions of a second, and so you didn't remember what you read, but while your brain was going to sleep. It can also happen when you're driving. Has this ever happened when you've been tired, maybe driving to work in the morning, and all of a sudden you're 3 miles down the road and you have no idea how you got there because you have no memory of driving those miles? What happened is your brain was going to sleep. You were alert and paying close attention, driving carefully, but your memory wasn't turned on during the time the brain was going to sleep. This happens with kids a lot when they're told what their homework is, and they're nodding their head and saying yes, but if their brain is going to sleep, they won't remember what they were told their homework was. So when it comes to doing their homework, they can't remember. Even things as simple as take out the garbage. I know parents who keep telling their children over and over, take out the garbage, take out the garbage. And the child says yes, but their brain has just gone to sleep and they forgot or didn't remember, had no memory of the parent telling them to take out the garbage. Another problem with the mouth breathing is enlarged tonsils. And there's a question of whether or not the enlargement of the tonsils comes first and then the mouth breathing, or if the mouth breathing comes first, dries out the tonsils, causes the infection, and causes the enlargement of the tonsils. I'm tending to think more toward, for the majority of people, probably not all, but for most people, it's the mouth breathing that leads to the infected tonsils. And here you can see what the tonsil is. The infected tonsils squirt out pus. The pus dries in that dry mouth situation of mouth breathing, and there we have the tonsillets. So which came first, the chicken or the egg? Did the mouth breathing cause the enlarged tonsils, or the enlarged tonsils cause the mouth breathing? I think it's mouth breathing leading to enlarged tonsils. So here's something you can look at your patients to see. Do you have any patients who snore? Looking at that and asking people, is snoring a problem in your house? And many couples today are sleeping in separate rooms because one or both are snoring. And this is definitely something you can help address with your patients to determine if, in fact, they're sleeping separately because of snoring. And of course, the one who snores swears that they're not snoring because it doesn't bother them. It only bothers the other partner in the bed. When the mouth is open, the air goes in through the mouth and over the tongue, and the soft palate will vibrate. We can also have snoring when the mouth is closed. When the tongue falls down off the palate, you'll still get vibration of the palatal tissues from nasal breathing. So you'll get snoring then as well. An important question to ask your patients too is, do your children snore? This is important because children should not snore. And you can see some of these are very young kids with their mouths open, and they're not getting filtration through the nose. They're not getting nitric oxide. The air going in is not going to give them the amount of oxygen absorption they would be getting if they were breathing through their nose. So what's going to happen is these kids are all going to sleep maybe 10 hours, but they are not going to sleep in a regenerative level. And when they wake up, they're going to be cranky and they're going to be tired. They are going to then have signs of sleep deprivation. Karen Bonnick is a physician who did a study of 11,000 kids who were 6 months to 7 years old. And she looked at mouth breathing as sleep disordered breathing, mouth breathing, and snoring. And she asked the parents if their child snored or was breathing through their mouth. And she found that the kids who this was happening to we're going to have behavior problems later in school, and that this should be addressed within the first year of life. Now, if they're just a year old and they're going to be sleeping with breathing through their mouth for a year, they're going to be sleep deprived for years, and this is going to lead to big problems for them later in life. Also, the extraction of bicuspids can be a problem that will push someone to become a mouth breather. This is my stepson, Paul, who's an attorney in LA. He had his bicuspids out. His father was an oral surgeon, and the father and the orthodontist would trade off treating each other's kids. So when it came time for ortho, Paul's dad took out his wisdom teeth, and the orthodontist said, take out the bicuspids as well. And Paul has now had 5 rounds of orthodontics and still can't get his bite corrected. And at the last session of this, they said, well, we're going to have to do double jaw surgery and essentially undo what the orthodontist did and pull the jaw forward where the orthodontist had pushed it back. And he was ready to go in for the surgery. They called him the day before for final instructions, and they said, oh, by the way, this probably doesn't even matter to you, but you won't be able to jump out of an airplane for about a year. And Paul said, okay, that's good enough for me. Cancel the appointment, because he jumps out of airplanes all the time, and he is a jump master in the Army Reserves. So he needed to be able to jump out of a plane, and if he couldn't do that, he wouldn't go for the surgery. So the bicuspid extractions and retractions will cause problems that will then lead to someone becoming a mouth breather. And there's a orthodontist in California who calls it the extraction, retraction, regret syndrome, because now he treats a lot of people opening up those extraction sites to put implants in to actually open the airway, because as the jaw is pulled back, it impinges on the airway. So when we extract and retract, because of the bicuspids, it crowds the airway. What also happens is the tongue appears to be too big for the palate, and it drops down and no longer stays in the palate. The DNA in the palate, teeth and tongues is all set to be the exact right size. So if the tongue is in the roof of the mouth and rests against the palate, stimulating DNA and stem cells right through the midline of the palate and around all the periodontal ligaments, the palate will grow to the exact size to fit all the teeth and the tongue. But if we take teeth out and retract and push back the jaw, then there won't be enough room for the tongue, and the tongue will drop down, and that leads to then mouth breathing, also leads to the tongue falling into the throat, leading to sleep apnea. Many times with these cases, you'll see cross bites after the bicuspids have been extracted and the teeth pulled back. And some of the teeth may be straight, but then the face is pinched. And what you can't see then is how much of an impingement was made on the airway. So for Paul, his next step is going to be an appliance that mimics the tongue after the fact and actually stimulates the DNA in the midline of the palate and in the periodontal ligaments to actually grow the palate laterally and anteriorly. And that will then open the airway. And this is really the only treatment for sleep apnea. Using a CPAP or an appliance will treat the symptoms, but it won't treat the cause of the problem, which is a high vaulted, narrow palate. So we want to be able to help these people. And what they found is that they can get the palate to grow in 18 months. And it's better to do a little treatment over 18 months than to tell someone they have to use a CPAP for the rest of their lives. Also, it gives an opportunity for people like Paul to actually get back the anterior growth of the arch that he was missing because of pulling it back. So this is one appliance for that. There are others as well, but I've taken some courses from Dr. Dave Singh, and it's just a very clever approach to doing this. And I asked one time a group of these Vivos doctors who have learned how to use this appliance, what is the oldest patient you've treated? And I was quite amazed to hear that the person was in their 80s and going through this to treat their sleep apnea and actually gained space for their tongue in the roof of the mouth. So what does switch someone from nose to mouth breathing? We've seen a lot of different things here now with bicuspid extractions, things like that, but most commonly it's colds, allergies, asthma. Asthma is a condition that really pushes someone to mouth breathing. And if you can treat the mouth breathing, you can actually cure the asthma. Other things that push people to open their mouth and drop their tongue will be lots of orthodontic appliances, piercings, different kinds of appliances that get in the way of keeping the mouth closed. And sometimes there's so much acrylic in their mouth, there's no way that the person can actually pull their lips together, and this forces them into mouth breathing. Even some CPAP machines don't cover the mouth, so someone may have the CPAP on, but their mouth is open and their tongue is down, so they aren't in the ideal position. So they're not actually correcting the cause of the problem. There are other habits that people have that keep their mouth open and tongue down. Chewing on pencils, pens, chewing gum, and it's amazing to me how many people chew their gum with their mouth open. You'd think they chew with their mouth closed, but they don't. They chew with their mouth open. Other influences are baby bottle feeding instead of breastfeeding. With breastfeeding, the tongue and the palate actually grasp the nipple and have to pull milk from the breast. With the bottle, the milk comes out so quickly, the tongue goes down and forward to slow the flow sometimes of that milk. So the baby bottle early in life encourages the tongue to be down and forward, which then easily can lead to mouth breathing. But when mom has to feed the baby with a bottle, they can get the baby to put the tongue back to the roof of the mouth very easily. It's called neurostimulation. And you take just the handle of a wooden spoon or those green sticks from Starbucks that they put in to keep the drink from spilling, and you just rub the tongue straight out 3 times and the palate 3 times, very gently. Tongue 3 times, palate 3 times, tongue 3 times, and palate 3 times, and the tongue will go to the roof of the mouth, even in a newborn baby. It's just the neurostimulation that tricks them and tells them to put the tongue to the roof of the mouth. So once bottle feeding is finished, just getting the tongue back up to the roof of the mouth will give the benefit that the getting the tongue up would be. Breastfeeding is the best because it does teach them how to suck and swallow appropriately, whereas the bottle, it's too quick and too easy. Also, sippy cups and pacifiers hold the tongue down and forward, and anything with getting in between the tongue and the roof of the mouth is going to lead them to the tongue down and forward position, which then can lead to mouth breathing. digit sucking, thumb sucking, any of these habits are going to have impact. And it's hard to get a baby to stop, but once they get to at least about age 4, trying to get them off the thumb or off the pacifier, that's the time to start. So we talked about the palatal development, and it depends on the tongue resting in the palate. And as you can see here if you imagine the midline of the palate, around the periodontal ligaments of all these teeth are stem cells and the DNA that's programmed to grow the palate to just the right size for all the teeth. So when you swallow, you'll feel your tongue, if your tongue is resting normally in the roof of your mouth, you'll feel your tongue roll from the tip to the middle to the back. And as you do that, it's stimulating stem cells and DNA, and that works as an orthodontic appliance. And you swallow when you're eating, but you're swallowing all the rest of the day with the saliva. And people swallow anywhere from 500 to 2,000 times a day. And that is an orthodontic appliance triggering natural growth of the palate. But now we can see narrower palates where the bicuspid has been removed. If you see the two cuspids crossing over, you know that you've got a problem of a very narrow, high vaulted palate. And that leads to the crooked teeth, especially with the cuspids, canines being pushed out. That's not from DNA, that's just from the tongue being down and forward, not up on the roof of the mouth, triggering full growth of the palate. And we see so much malocclusion these days that it makes you wonder, is anyone putting their tongue to the roof of their mouth? Are they all mouth breathing? This one you can almost see the thumb, where this little kid was sucking their thumb and had the palate practically grow around the thumb instead of around the pressures of the tongue. Now, many orthodontists, even today, think that malocclusion is really genetic and there's nothing that can be done about it. But Dr. Harvold in the 60s, he was an orthodontist, he noticed that many of his patients were mouth breathers. And so he really was pushing the idea that mouth breathing could lead to crooked teeth, but no one of his colleagues would believe him. And so he did research in 1981 where he actually created malocclusion by switching monkeys from nasal breathing to mouth breathing. And the way he did this was to place silicone plugs into the nostrils of the monkeys so they couldn't breathe, and then actually put an implant into the roof of the monkey's mouth, like a block of plastic that would keep the tongue from resting in the roof of the mouth. And with this, he was able to actually create malocclusion because of the switch from nose to mouth breathing. And what happens, we've looked in the mouth, now let's look at what happens to the face with this mouth breathing. And what happens is what's called long face syndrome. And you can see this little boy, open mouth, tongue down and forward, and that vacant stare in his eyes. It looks like he's not getting good sleep. He's not getting enough oxygen to reach his brain to actually sleep in a regenerative level. So, you know, when people talk to him or give him assignments for school, he's going to have his brain go to sleep in fractions of a second, and he won't remember his assignments, and he will be accused of being lazy and not paying attention, when in fact, it's because he's mouth breathing and not getting enough oxygen to his brain. As you look at this little boy with the long, narrow face, that vacant stare with his mouth open, tongue down, and you can see even under his eyes, it's flat, not growing forward the way it should, dark circles at shortened upper lip, and the lips are flaccid. They haven't been engaging. And the lips, when they're closed, are amazing because they create such a perfect seal that no saliva drips out. But when the mouth is open, that's when you'll see drooling. But the lips are muscles, and just keeping the lips closed activates those muscles. Look at some other facial changes. This is a little girl who's 6 years old in the left of this picture. And I always thought at age 6, you wanted the teeth, the deciduous teeth, to look like a picket fence, that the jaw is growing enough so that there will be space for the permanent teeth. And as a mouth breather, she wasn't getting her tongue to the roof of the mouth, did not get the palatal growth that she needed laterally and anteriorly. And you can see her on the right at age 9, and now the lip is behind, the teeth are pushed out. What happens with these kids when they have their mouth open, they develop what's called a reverse swallow, where they push their tongue forward to swallow instead of pushing it up to the roof of their mouth, which then causes tongue thrust and pushes the anterior teeth out. This is another patient. This is a patient of Dr. Muse in England. This is David. He, in this picture, was 10 years old. He was a nose breather at this time, very good looking, broad-faced. Everything was in good proportion. But for his 10th birthday, his parents bought him a pet gerbil that he kept in a cage in his bedroom. And what David didn't know, what his parents didn't know, is that he was allergic to the fur and dander of the gerbil, and he switched from nose breathing to mouth breathing when his nose became congested from the allergies. Here he is at 17. You can see his face has changed considerably. Look how far back his chin is. His chin should actually be out in line with his forehead, not way back here. And you can see the whole face has not grown flat under the eyes, so the sinuses haven't grown completely. So smaller sinuses, smaller airway, shortened upper lip, which makes the nose quite pointed. So think of looking at your patients, not just from the front on, but look at the side to see how their profile looks. Here you can see the change considerably between David on the right when he was a nose breather and what happened when he became a mouth breather. Something else you'll see is below the chin. David on the right has his tongue up to the roof of his mouth, and there are 8 muscles attached to the tongue that are all activated when the tongue is on the roof of the mouth, so that tightens the neck muscles. On the left, David, older with the tongue down, none of the muscles are activated, so it leads to that lack of definition in the chin and sort of a double chin. Here are sisters, Kelly and Samantha. Kelly is 7 years old, Samantha 8.5. Kelly's a nose breather, and Samantha is the mouth breather. You can see the difference already, and as pretty young women, you can see the difference as well. Still both pretty, but Samantha is forcing her lips together because she's much more comfortable with her mouth open. Here's a typical profile where you can see flat under the eye, dark circle, that shortened upper lip, the pointed nose, and the chin back quite a ways, and no activation of the tongue muscle, so no definition in the chin. Well, body posture often too of mouth breathers is with the slouched posture. And if you sit there for a few minutes with your mouth open and your tongue down, things get very heavy and it pulls the shoulders forward into a slouched posture, and then the kids will push their head forward to open the airway. So a very typical posture of a mouth breather. Then looking at where we want the tongue to be, we want it to be up in the roof of the mouth, and in many of these cases we've seen that the tongue is down and forward. And we're seeing, in some cases, the tongue is between the teeth, often biting on the tongue as like a bite guard. And you'll see sometimes in patients indentations on the side of the tongue where they're actually bracing their tongue against the teeth. They don't have it up, but if you don't have it up, it gets heavy and they push against the teeth. So checking to make sure the tongue can actually move and get out, we want to see how far we can get the tongue out. So that tongue rest position is up on the palate, not against the teeth, but up against the incisive papilla, essential for palatal development. It also allows for proper breathing, chewing, and swallowing. And mouth breathers often chew with their mouth open because they're breathing, and they often drink a lot of water or whatever liquid they're drinking with their eating because they aren't using their when normal eating. Next time you eat something, just kind of analyze your chewing and swallowing. And what normally happens is as you chew something, you then make a ball of it on the top of the tongue, and then the tip of the tongue goes to the roof of the mouth, and the tongue rolls back, and the food goes over the top of the tongue and down the throat. But for mouth breathers, they swallow with their tongue down and forward, and they need the liquid to help push the food down the throat. So that's the problem too. It's so many reasons why we want the tongue up on the roof of the mouth to allow not just for breathing, and if you put your tongue to the roof of your mouth now and open your mouth, if your tongue fits snugly to the roof of the mouth, you will not be able to breathe through your mouth. It blocks that, and that's what we want to ensure nasal breathing. And of course, chewing and swallowing are also very important. So some people say, well, it's okay. I'm breathing through my nose, but I don't have my tongue up. There's still problems associated with the tongue down and forward. So breathing with the tongue position up on the spot, lips together, teeth apart, and that will allow for only nasal breathing. So you can try that now too. You can't breathe through your mouth if you have your tongue on the right spot up there. So proper tongue rest position is not like this, but growing up in Minnesota, we were every kid was told at one point or another to put their tongue on a metal post somewhere and they got it stuck. So we all learned, but not as quickly as we probably should have. So another problem with the tongue not being up to the roof of the mouth is that this can lead to clenching, and this can lead to problems with the temporomandibular joint, leading to TMD. The tongue, there are 8 muscles, extrinsic and intrinsic, that attach to the tongue, and the tongue actually holds the lower jaw up. There's a sling through the joint, but when your tongue is in the roof of the mouth, it holds the lower jaw. Now, if you drop the tongue, there's nothing to hold the lower jaw, and it becomes very heavy. So if someone is in a position with the tongue down and and the lips are closed, what ends up happening many times is they will then clench to hold their jaws together because the lower jaw becomes heavy. The normal tongue holding it makes it very comfortable. So check with your patients who are clenching to see if their tongue is down. Just check, is it down and forward or is it up in the roof of the mouth? But clenching often is done to alleviate the weight of the lower jaw and hold that lower jaw up. So what you can do for these patients is, which also gets them away from mouth breathing and keeps their tongue up so it doesn't have the tendency to fall in the back of the throat during sleep, is just getting them to rest their tongue in the roof of their mouth, lips together, teeth apart, tongue up. And with that and the teeth apart, the tongue will hold the lower jaw and there won't be any need to clench the teeth. So check if the clenching is caused by the need to hold the jaw up because the tongue is down and forward. So what if that tongue can't reach the palate? This is a serious problem. And what we see with this is with tongue tie, the babies are unable to latch onto the breast. And what often happens is they will fail to thrive. Males affected by this more often than females. And in many cases, this should be treated right away in the hospital within the first few days after birth so that the baby can latch on and start nursing. But many times it's delayed till much later. If the mom has trouble nursing, they then go to the bottle and try to do that. But the baby will also have problems with the bottle because they can't get the tongue up to push the nipple of the bottle against the roof of the mouth as well. So it creates double problems. Here is one later, and you see the typical tie of the tongue creating that V-shaped look of the tongue. And you can imagine they can't get this tongue up and they can't swallow properly because they can't get the tongue to the roof of the mouth. So frenum length, we want this one on the left, you can see is adequate, but you can see on the right, it's so tight, it's actually pulling between the teeth and pulling the teeth out of alignment. Another one you can see as the V shape when they try to lift the tongue, but also when they stick their tongue out, it also forms another V. And with tongue-tied patients, they can't get their tongue past the lower lip. So you really want to check for that. Another aspect of tongue tie is that it could have two ties. One, it could just simply be the ligament that needs to be released, but in about 90% of cases, there's also a muscle involved in the middle of the tongue. So if you check for the tongue tie and find it to the tip of the tongue, then have them stick their tongue out and see if you can see it pulling down in the middle of the tongue. And that will be indicative of the muscle in the middle of the tongue pulling down. So it needs both the ligament and the muscle released. These are restricted frenums, not from the very tip of the tongue, but definitely not enough of a leeway that they could get their tongue to the roof of the mouth. Here's another one from Dr. Eberhardt here in Phoenix. You can see this kid's already in braces and needing the braces because probably of the mouth breathing and the tongue tie and not being able to get the tongue to the roof of the mouth. And you can see here, this is a day or so after the laser. It's already beginning to heal, but you can see how much movement the tongue was able to gain just by releasing just the ligament, giving the person a lot more option to get the tongue up to the roof of the mouth. So now we've looked at a lot of things leading to mouth breathing, especially habits that lead to mouth breathing, because mouth breathing is that precursor to sleep apnea. So if we can identify the mouth breathers first and help them to get the tongue back to the roof of the mouth closed and breathe through the nose, then we can have some impact to help screen and prevent the sleep apnea. So here are going to be some simple steps that can help patients. So before you say open wide, let's look first to see what the person looks like. And one thing you can do before the screening exam is just watch the person as they walk from the reception area. And even if you walk a few steps backwards and look at them, they may at rest sit with their mouth closed, but as they move, do they open their mouth and begin to breathe through their mouth? So checking, are their lips together at rest? Do they open their mouth when they actually move? Looking to see, can they breathe through their nose? That's a question. You want to test their nasal breathing to see if the nasal passages are open. And then as we looked before, look at where they have their tongue and a quick way to check frenum length. So let's look at these. So looking first, is their mouth open? Are their lips together at rest? The one in the lower right is Maria, who I worked with. And you can see her tiny little nostrils. She never used them, so they're not very wide open. She's been a mouth breather for a long time. You can see the two teeth showing, the tongue down and forward, and she's been working on exercises to try to get the tongue up to the roof of the mouth and get back to nasal breathing. Also, questions to ask patients when they wake up, when you notice that they have an open mouth posture. Do they wake up with a dry mouth? Do they ever notice that they're drooling, either during the day or while they're sleeping? If they're drooling, their mouth is open because, as I mentioned before, those lips make a perfect seal, and without that perfect seal, the saliva will drip out. So sometimes people will notice that when their mouth is open because of the drooling, or if someone else says something, but watching television, working on the computer, driving or reading, but just being aware of whether or not the mouth is open and asking patients to take a look. Do they notice when their mouth is open? Step 2 is nasal breathing. You don't need to stick your finger in the nose, but just take a finger on the side of the nose or under the nostril, in and out on one side, in and out on the other side. Can you tell me then which nostril is more open? right or left? And keep that in mind and just notice how open your nostrils are, because we'll look at an exercise in a bit to see how well you're doing. Why don't we, maybe Carrie can do this. We can have a little quick, little post in the chat. How many can breathe better through the right side? How many can breathe better through the left? So put right or left, and we'll see what you're finding. And what that actually means is which side of the brain is more active, and that side will open up. So you've probably noticed at some point when you've been plugged up, one side is open and one side is plugged up. Have you ever noticed it instantly switch to the other side? Also do an exercise to open up the nostrils to see if you notice you can get more air in or not. So thanks, Carrie, for checking on that for me. So other questions you can ask the patients about if they suffer from allergies, if they have allergic rhinitis, lots of runny noses, just asking about whether or not they've had frequent colds, and you'll tell if they've had their tonsils removed, or ask about their adenoids. Also ask about the patients who report that they have asthma. Do they use an inhaler? Those kinds of things to find out where they are, because you'll be surprised how many of your patients, as you start looking at this, are mouth breathers. So step 3 is that tongue posture, up, down, or in the middle. And now if you ask a patient, where is your tongue, they kind of want to give you the right answer. So don't give them any information beforehand and just say, right at this minute, tell me exactly where your tongue is, up, down, or in the middle. And most people will have it up, but at least 10%, and even in this group, 10% will have the tongue down, and a smaller percentage will have the 10% down, and about 5% will have the tongue between the teeth. So that might be something else if you feel like writing that down. Where is your tongue right now? When I was a mouth breather, my tongue was in the middle as a bite guard, and I would have the indentations in the tongue from bracing against my teeth. So I was in that group. Some of you, I'm sure, may have a little tongue tie or may just have a habit of keeping the tongue down, about 10% of you, and the rest will have your tongue up to the roof of the mouth. The step 4 is frenum length. Is it okay or is it tight? Now, the 2 steps to check this is to go first with 3 fingers and just open your mouth as wide as you can and see if you can get 3 fingers in. That's how you want to check, just full open mouth, and then put the tongue up to the roof of the mouth and see if you can get 2 fingers in. So some of you might be able to get 1.5 fingers or 1 with your tongue up on the roof of the mouth. So just take a look. This is a quick screening device that you can use with patients. I know there are lots of forms you can use to check screening for sleep apnea, but this is a quick way you can do it that doesn't take very much time, but gives you a lot of good information. So looking whether or not the lips are together at rest, nasal breathing, whether they can breathe through their nose, where their tongue is, and checking that frenum length with 3 fingers for a full open and 2 fingers for tongue on the spot. Okay, so now what can we do to help convert these mouth breathers back to nasal breathers? The number 1 step is awareness, just helping people know there's a difference between nose and mouth breathing and what the value is of the nasal breathing. And unclogging the nose, if they're plugged up, we'll go through that exercise. And then you might think this is crazy, but actually taping the mouth shut. So looking first at awareness, just bringing up the topic, finding out if people even know themselves that they're mouth breathing. I didn't know I was, and it wasn't until someone made me aware that I was breathing through my mouth and that I would be better off breathing through my nose because I would get more oxygen to my brain and sleep in a regenerative level and be much more rested during the day. So just talking to patients about it is helpful. The next is unclogging the nose. So let's take a look at that. Let's see, I see some messages, fingers in. Some people sleep better with tape. Awareness is key. That's a good one.
It's 7 o'clock.
Oh, I apologize. I tried to turn off my clock telling me the time, which meant I should get up and do some exercises instead of sitting at my computer too long. But there you go. I couldn't find it fast enough. So let's try unclogging the nose exercise. It's really an easy exercise to do. I'm going to have you close your mouth and put one of your fingers on your lips as a reminder to not breathe through your mouth. Then take a small breath in through your nose, a small breath out, pinch your nose, hold your breath, and move your head up and down as long as you can. Hold your breath. Keep holding your breath as long as you can. Hold your breath, and when you have to take a breath, keep your lips closed and take a small breath in through your nose. So now, after doing that, you might still be doing it, but once you finish, then try again, checking to see how open are your sinuses and your nostrils. Has anyone noticed that they can breathe easier after just doing this one exercise, just one time? You can do this up to 6 times in a row if you're becoming congested. Now remember I explained to you how the brain was plugging up the nose because the brain was measuring that the CO2 was exhaled too quickly and it wanted to slow the breathing down. So what you can do is trick your brain into telling the brain you're not exhaling CO2 too quickly, and the brain can unplug the nose, and it does it that quickly. So let's try it once more. Take a finger on your lips, take a little breath in through your nose, little breath out, pinch your nose, hold your breath, and bob your head, fingers on your lips, pinching your nose, hold your breath as long as you can. Keep holding your breath, hold your breath as long as you can. When you just can't hold any longer, keep your finger on your lips and just take a small breath in through your nose. And now, again, just after that second time, check it again. Anybody? This time, someone said it didn't help. Someone said, yes, it did. Wow, better. For those who haven't helped, go ahead and try it a couple of times to see if it can help. Even if you're in bed at night and all of a sudden you're feeling congested, you can do this exercise lying down, sitting up, anywhere, and it seems to help. I have neighbors down the hall, 2 sisters, one's 84 and the other's 92. The one who's 92 finds at night she gets congested, and she does this in bed and helps to make sure she can breathe better through her nose. Another way is with clear nasal spray. So if you wash your hands every day, you could wash your nose. And if you use the xylitol nasal spray, this product contains xylitol, a tiny bit of saline, because you can't call it a nasal spray without saline, grapefruit seed extract as a preservative, and water. And that's all it has, but it will help pull fluid from swollen tissues and help you breathe better through your nose. So a great way to, if you do that, if you don't have the clear nasal spray, you can do the unclogging exercise, but using the clear nasal spray morning and night is a great way to wash your nose. We wash our hands, why not wash our nose? And now there's some very interesting research that has been done with COVID, and 3 different independent studies, Utah State University, Tennessee, and Geneva, have looked at the different types of the clear nasal spray. They have different, some that are more potent with different ingredients. These are the average ones. And they have found that the clear nasal spray will inactivate COVID virus in 15 minutes in the laboratory study. So that's pretty amazing. And so they've been doing studies with patients in Florida. There's a pulmonologist who is working with patients through a hospital, and all the patients coming into the study have to have a positive COVID test, symptoms of COVID, and underlying health issues. And what they found is once they are positive, have the COVID symptoms, they enter the study, they're given the clear nasal spray, and they squirt their nose every 4 hours, because the mucus within the nasal passages is on about a 4-hour cycle that you go through that 4-hour cycle and you have new mucus. And so that's why they picked the 4-hour interval. And what they found with these people using the clear nasal spray is that their symptoms were much reduced by day 7. By day 7, they had a negative test. And by day 14, all symptoms were gone. Even taste and smell were back. And they tested negative with 0 symptoms in just 14 days. And 2 of these people were obese. One had heart disease. One was had cancer and was doing better. But all of them had these comorbidities. And it makes sense, if you can wash your hands with soap and water and get rid of the virus, doesn't it make sense to wash your nose? 90% of the virus is going to be found in the nose and 10% in the throat. So definitely worth trying. It's been on the market for 20 years. Many people pronounce it Xlear, even though it's pronounced clear. The X is silent for the xylitol, but that's what happens when you let a physician name the product. So X-Clear or Clear, whichever you want. This is the child size bottle, just easier for a child to squeeze that as opposed to the one on the left with the pump. But the solution in the bottles is exactly the same. And in the one on the right, you can put the packets of the crystal xylitol into the bottle and squirt it higher up into the sinus, and it comes out the other nostril. So different ways to use that. But interesting research that they're showing now with the clear. There's another product from here in Phoenix, Closis, which is a chlorine dioxide product, which is great for rinsing and gargling. And when you have your patients rinse, be sure you have them gargle, because gargling is where the virus will be, or the bacteria, not just in the mouth, but in the throat. So be sure to gargle with it as well. So when you're using the spray, look at your toes, squirt and sniff twice in each nostril, at least once in each nostril or twice. Either way, it can work. Sometimes if you squirt twice, for some people, they don't have as much congestion and it tends to run out, so you need to blow your nose. But anyway, if you're using it and you're a bit congested, it will pull fluid out and you'll need to blow your nose. So I blow first, then I squirt, and then I blow again. So remember Nathan, who I introduced to you in the very beginning. What his mom learned to do was to use the clear nasal spray and squirt it morning and night for just 3 mornings and 3 nights to make sure he could breathe through his nose, and then kept squirting. And after he fell asleep, she would gently pinch his lips for 1 hour, just 1 hour in the night. She did that for 3 nights, and he slept through the night for the first time in 6 years. So she used the clear to make sure he could breathe through his nose, and then trained his lips to be closed by just gently pinching them. She just wasn't ready to use tape on his lips, so that's how that worked out. But amazing, that's all it took, and that the physician wasn't looking at breathing as an important part. And medical school doesn't really teach the difference between nose and mouth breathing and how important it is to be nasal breathing for all kinds of reasons. I have a daughter-in-law who's a physician who teaches in a medical school, and we've talked about this a lot, and she said, nope, they don't cover that at all. Breathing is just breathing, everything's the same. So she, in teaching her students now, has added all this information about the importance of nasal breathing, and I've learned from her about the respiratory centers in the brain and the measurements of CO2, so it's been a fun collaboration. So think about Nathan and how that changed his life, to breathe through his nose, get enough oxygen to his brain to sleep in a regenerative level. And the real key here is, besides getting a good night's sleep, it allowed the release of human growth hormone. So he started growing very quickly. When he wasn't sleeping and was waking up during the night. He wasn't sleeping in a regenerative level, and the human growth hormone is only released when sleeping in a regenerative level. So that's what happened to Nathan, and his mom was surprised how quickly he started growing and how often she needed to buy new clothes as he was growing so quickly. So she's very happy with the results. So when I mentioned the tape before, and there's also a gel, so let's take a look at that. Micropore paper tape is what works the best. It's the most inexpensive. There's a sensitive brand, and it's just the white medical paper tape that's so easy to find. Many of you have it at home as well. And be sure before you use tape, though, that you do make sure they can breathe through their nose. So this was a class I was teaching. I think this was actually in New Zealand, and they were having fun taking pictures of themselves and making funny faces. But when you use the tape across the lips like this, just fold the edges in. So in the morning you have something to grab onto. It makes it easier to take off. Also, before just taking the tape off, push your tongue through, get the tape wet so you don't just rip it off, taking any hair or skin with you. So just make it easier to take it off. This is a nephew of mine who figured out he needed more than one piece of tape. He'd been a mouth breather, snoring terribly, and we worked with him and his mom, and finally he got the frenectomy and worked well to then get his mouth closed and get his mouth closed and stop the snoring and breathe through his mouth. But he liked more than one piece. And I must let you know this is not child abuse. And I really think every child in the backseat of a car should probably be taped. It's a great time for them to practice breathing through their nose and letting mom and dad drive the car without all the chatter that's going on. So definitely not child abuse. But never, ever, ever use duct tape. That is a no-no. You want something that can be taken off easily during the night. And even if you need to, you can open your lips easily with surgical paper tape, which you can't do with the duct tape. So never, ever use duct tape. So again, only the micropore paper tape, easy to find in the drugstores or online. There are lots of other tapes as well. Some of these are much more expensive. This one in the middle, you can see has a little hole in the middle. It fits around. It's very nice adhesive, but it's more than $1 a piece. So you're spending a lot of money to put the tape on as opposed to a $4 roll of tape. The one on the left has a little bit across, under the nose, across the lips, and across the chin. The one on the right is called myotape, and this was developed by Patrick McEwen, who is the one who teaches Buteyko breathing. I've studied with him. He's in Ireland. But he found that children weren't liking the tape as much. Parents were afraid that the child wouldn't be able to open their mouth if they wanted to. So he created this very sticky, stretchy tape that you stretch before you put on, and it pulls the muscles and closes the mouth. But if you wanted to, you could actually open your lips. So that works well for kids and adults. And I had friends here, a couple staying for a week, and the wife had been diagnosed with sleep apnea, and she tried the tape, and I said, here, try these. And she was amazed at how well she slept and how comfortable it was to wear the myotape, and less expensive than the fancy other tapes. So, and some of the others are just different pieces of tape. But lots of different approaches to try and help people train to keep their lips closed. Another one is called Sleep Q Plus. This comes from Australia. It's actually a New Zealander who developed this gel, and he worked on it for a long time. The reason he came up with this is because he had nasal polyps. He had surgery, and every time he had surgery, the nasal polyps came back. And he just said to the doctor, this is crazy. It's not working. The nasal polyps come back. And he said, well, you should be breathing through your nose. And he said, well, I can't breathe through my nose. That's why I have the surgery. And he said, well, you can always tape your lips shut. And he was mortified to think about taping his lips. And so the physician said to him, well, if you can come up with another solution other than tape, you might be onto something. So he worked for several years developing this food grade gel that you put on the lips. And these are my lips, putting it on the left, you get it wet, and then you put the lips together, and you can see it creates a seal right in the middle, but you can actually open the sides of your mouth if you want to tuck a straw in and take a sip of water in the night. But they're waiting now. They've had a little glitch where they're trying to move the production to the States so that they don't have to ship from Australia. So we'll see how soon that goes, but you can check out the website sleepqplus.com.
Trisha?
Yes.
Hi, honey. It's 15 minutes.
Okay, we're just about wrapping up, and we'll have time to ask some questions. Okay, if you're going to be ready with any questions for me, that would be great.
I have some ready. Thank you.
Okay, perfect. I appreciate it. So these are the steps that you can follow to help convert your mouth breathers to nose breathers. And mainly the awareness, sometimes just getting people to know they should close their mouth is enough for them. Others may need to unclog their nose and tape their lips. And some people can tape their lips and exercise their tongue to get the tongue to rest on the roof of the mouth in just 3 months. Others, my son-in-law will tape forever because he doesn't want to risk not getting a good night's sleep. He's convinced it makes it so much better. And he does slip into mouth breathing during the day. So those are the things to look at. We talked also about the neurostimulation for babies, to just rub on the tongue 3 times, palate 3 times, and repeat that 3 times to get the tongue to the roof of the mouth. Also, I have a videotape on YouTube. If you put my name in and myofunctional, it's a tape. It's just a funny little video of exercises that I did for my son-in-law, grandson, and nephew, who all had frenectomies and needed to get their tongue strong enough to stay to the roof of their mouth. And I've just put it up there so they were all over the country to be able to watch the exercises. But for some reason, other people have found it, and it's had over 50,000 views. So I don't know who's looking at it, but someone. And people have written notes about it too. So if you're curious about some exercises to show your patients, it gives you more of the details. One exercise is the tongue pop. But some people tend to pop the tongue. What you want to do is get the tongue to the roof of the mouth, make it stick like it's stuck with peanut butter, and then use your lower jaw to pull the tongue. So fight against the tongue with the lower jaw, and that actually engages all the muscles from the tongue, and your neck will be sore after doing that 25 times. So look for that. YouTube, Trisha O'Hare, Myofunctional. If you want more information, there are several books out that are very interesting. No More Allergies, Asthma, or Sinus Infections is written by Dr. Lon Jones, who is the inventor of the clear nasal spray, a family doctor. Lip Sip is a book that Tim Ives and I have written, stories about people we've helped switch from mouth breathing back to nasal breathing, plus a section on the science of how that happens, and a nice bibliography. It's just a little mini book. And we also have a video online if you want to take a course that's more in depth than this at lipzipbook.com. The one on the right is Patrick McEwen, who I've studied with for Buteyko breathing, the oxygen advantage. He's really the guru. And if you want to learn more about breathing, Patrick is the one to check into. Breath from James Nestor is a real popular book right now. He was writing that and ran into my videos and articles online, gave me a call and asked me some questions as he was writing his book. But he and a colleague from Sweden, he lives in California, they got together and they went to the university in California, which one I can't remember, but they were in a research project. They probably had to pay for it even, where they were forced into mouth breathing for 10 days and then forced back into mouth breathing for 10 days. And they monitored everything that you could think of and ate exactly the same food and did things at the same time, so that the only difference in their life was the mouth or nose breathing. And it's an amazing read. He's a really good writer. but he was able in 10 days to force sleep apnea with mouth breathing. So the mouth breathing is the critical factor that can then lead to sleep apnea. So he was very happy to end the 10 days with their nose taped shut and their mouth wide open and mouth breathing. So a very interesting read if you want more about the impact of mouth breathing on life and on sleep apnea. So I really hope that now you have an understanding of the value of nasal breathing. I hope you can now identify some problems in your patients of mouth breathing that if you intercede now, you can prevent sleep apnea for them later, and that you can improve your own nasal breathing and that of your family and your patients. So I want to thank you very much. We have some time for questions, but I want to be sure you had the code. So Carrie, are you ready with some questions?
I am. Can you hear me okay?
Perfect. Thank you.
Wonderful. Our first question, can the rapid and larger volume of airflow upon inhale and mouth breathing be injurious to pulmonary alveoli?
Very good. You pronounced it right. I don't know that it can be injurious. It's just that it's not healthy in general. It's going to overwork the alveoli, but I haven't really seen that leads to any damage. But the damage is by not getting enough oxygen to the brain to get regenerative sleep.
Okay, thank you. Have you heard of the Healthy Start system? And if so, what are your thoughts?
Healthy Start. I haven't. Specifically, if it's about breathing, I haven't heard of it, but sorry, I'll have to look into that.
Okay. Number 2, thoughts and opinions on Silent Night sleep appliance made by Glidewell.
Well, my concern about appliances is that the primary focus is to pull the lower jaw forward with the tongue to keep the tongue from falling into the throat. But then many times you have to put another appliance in the morning to put the jaw back so that it's where it should be. My concern with that appliance is it's treating the symptom, not the cause. But with that said, those appliances have been a godsend for many people. So if that works for patients, fine. But I would also look to see if you could find more of a cure to look at the cause of the problem and not just treat the symptom. But definitely has its place. But think too about more long term.
Okay. If someone has been clenching and they have a night guard because of it, is the night guard perpetrating the problem?
It could be, because it still could be that the night guard doesn't keep the mouth closed completely. It just protects the teeth from grinding. But if they're still not getting the tongue to the roof of the mouth, they may still be grinding just because they're trying to get the tongue, they're clenching more. The grinding often is done to open the airway, because if the tongue is falling back, if they clench and grind, and it releases more saliva and it allows that airway to open. We even see that with little children where they're grinding their teeth down just to try and get their airway open.
Wow, okay. Do you believe there is a correlation between epilepsy and mouth breathing / sleep apnea?
That's interesting. I've seen some work done on that. There's been some research done by some dentists I know on the East Coast where Tourette's syndrome has been treated very successfully by treating mouth breathing and sleep apnea. Again, it's the tongue, and it's anything that, the mouth breathing and the sleep apnea reduce oxygen reaching the brain. So it can have an impact on a lot of things that we haven't actually even had the chance to look into yet, but definitely very interesting. I'll keep an eye out to see if any research comes with epilepsy and mouth breathing and sleep apnea.
For sure. How much does a diet high in refined carbohydrates affect CO2 breathing at night?
Huge. The more refined carbohydrates that people eat, the more they're going to be mouth breathing. They open their mouth and drop their tongue. There is a dentist, what's his name? come to me a minute. Long in the 30s, he was looking, he thought there was some correlation between diet and malocclusion. And he traveled the world photographing tribes and cultures that had not been exposed to a Western diet. And in those groups, they had all of their teeth, all the teeth were straight, and they were nasal breathers. Now, when that culture was introduced to refined carbohydrates, the very next the parents were the first to eat the carbohydrates, and then the children, and their teeth were crooked, they were mouth breathers, they had a lot of decay, and it was just in the first generation that happened. His theory was that the diet of refined carbohydrates was missing some certain vitamins, specifically a vitamin K. But I also think adding to that was the switch from nose to mouth breathing, because then the tongue drops, the palate grows in, high vaulted, narrow palate, crooked teeth, a lot of decay, which is the combination of the sugar in the mouth plus the mouth breathing drying out the natural defenses that are in the saliva. So it's very complicated, but very interesting topic. I'm sure someone remembers the name of that dentist. I don't know why, I just can't think of it right now, but I know there are many in the audience who know his name. He's got a really good book about physical degeneration and diet.
Okay, I'll check the chat also, maybe as you're answering this next question, and it may need a little reference to, because she says, refer to orofacial myofunctional therapist.
Yes, absolutely. And many of you may want to become a myofunctional therapist or a Buteyko breathing coach. I think these are some really amazing skills for hygienists to have to offer to patients. Myofunctional therapists are either speech pathologists or dental hygienists primarily. And many hygienists bring this into their practice and then slowly move out of the practice and have their own practice of focusing on myofunctional therapy, teaching people how to chew, swallow, and breathe with lots of exercises and appliances and things like that. But definitely, if you have someone in the area that you can refer to help get that tongue back to the roof of the mouth, that's they're great. And you may want to look into becoming a myofunctional therapist.
Was the dentist you're thinking of Weston Price?
Weston Price, absolutely. Good resources in this audience tonight.
For sure. We have some more if you still are okay on time.
I'm okay on time.
Great. How do you feel about putting the dots on incisive papilla to help strengthen the tongue where to be?
Perfect. What that means is they put a little sticky dot up on the roof of the mouth and try and get the child or the adult to put their tongue up there. Definitely that can work. Another thing is just little tiny candies that are xylitol, and have the child hold the candy to the roof of the mouth with their tongue is another way.
Okay. You think that pretty much all types of malocclusion, overbite, underbite, crowding, etc. is from mouth breathing?
I can't say all of it for sure, but certainly a lot of it is if we don't grow the palate with the tongue resting in the palate, and once the palate starts growing narrower, you can't get the tongue in at all anyway. So it seems to me a likely logical cause, but I can't say it's everything. There's certainly other things that could have an impact, but this is a simple one to look at and an easy one to try and correct early on with kids.
Oh, okay. Have you heard of Vivos, and what are your thoughts?
Yes, Vivos, and that is that appliance that I showed you, originally called the DNA appliance for do not adjust and for impacting DNA, but the FDA didn't like the DNA part of that name, so they changed it to Vivos. But I think it's a great appliance, really based on a lot of scientific evidence, and seen great results in a lot of different people with it. So I think it's a a great option for people who need to grow their palate after they've gotten past age 12.
Oh, I see. Okay. This next one, you're going to have to help me out with some of these words. You talked about releasing lingual frenum.
Mm-hmm.
What about buccal,
Mm-hmm.
and upper lip frenectomy?
Absolutely, great question. We look primarily for the tongue, but many times when you see someone with a very gummy smile, it's because they have a tight buccal frenum. The upper lip frenum needs to be. So absolutely spot on to ask about that and to look at all the frenums and see what needs, if any else need to be released.
Okay.
And sometimes people can't get their lips together to get full closure because the frenum under the upper lip is so tight, it pulls the lip up pretty high. So definitely a good thing to look at.
Okay. Is there any correlation between mouth breathing and SIDS?
It does make you wonder, doesn't it? So if the child is actually mouth breathing and the tongue falls into the back of the throat, they could stop breathing and die. So I haven't read any specific studies about it, but it certainly makes me think. So I'm thinking the same way this person is too.
Okay, yeah, it sure does make you think. Can you explain nitric oxide process again? Do you teach myofunctional therapy?
Okay, nitric oxide, I'm glad you asked. It's so amazing that when you breathe through your nose, in the sinus will be released nitric oxide. And the nitric oxide then goes into the lungs with the air, and the nitric oxide will facilitate the release of oxygen and to be attached to get into the blood to go to the brain and the muscles. So just think of it as a helper to increase oxygen absorption. It does a lot of other things, but that's why it works. And that's why nose breathing is so important, because of the nitric oxide and the filtration, etc. But the mouth breathing, you get no nitric oxide and no filtration. And they're finding now with COVID, mouth breathing is a really big problem. And I've talked to friends who've had family members who are having trouble getting over COVID, even though they had mild symptoms and then having chest problems, chest pain. But when they watched, they were just breathing in the upper part of the lungs, not moving their diaphragm, not moving the heart, not moving the lungs or the digestion. And once they started breathing from the belly through the nose, their symptoms, in one case, the woman said, gosh, she felt 70% better just doing that. And she had gone twice to the hospital with the chest pains in the lung and worried about endocarditis of the heart, myocarditis, I should say. But just getting them to breathe through their nose makes a huge difference. So I don't know how I got off on that, again, about the nitric oxide. And then I don't teach myofunctional therapy. I've taken 2 classes. Because I was wanting to learn more about it, and the Buteyko breathing is, to me, the Buteyko breathing is the foundation. Once you have that, then the myofunctional therapy helps as well to help retrain the muscles.
Okay. Can adults that have sleep apnea correct it by learning to breathe through nose?
Yes. Now, the sleep, I can't say that because I'm not a sleep medicine doctor, but there are many sleep medicine doctors who say, no, if you have sleep apnea, you'll always have it. But I don't believe that. And I've seen cases that have been able to reverse it completely by switching back to nose breathing, getting the tongue to the roof of the mouth. Like James Nestor did in 10 days. He gave himself sleep apnea and then reversed it. But I know other people have had sleep apnea for a longer time. 2 clients of a fellow who studied Buteyko breathing when I did. And he worked with these 2 people and they had no problems anymore. And they asked if their sleep apnea was cured. And he said, well, I can't tell you that, but if you go back to your doctor and take another sleep study, you can test it that way. So these 2 different fellows went back to their doctors and the doctor said, no, it's impossible to cure it completely. So he said, well, we'll take another sleep study. So the first guy took the sleep study, breathing through his nose, mouth closed, and he came back 0, absolutely no sleep apnea. And the physician said, I think the machine's broken. We have to do it again.
Oh my.
So he just wasn't open to it. But I've seen so many people improve simply by changing their breathing. I can't say that's the answer for everyone, but it's a screening tool and definitely worth testing to get someone to just close their mouth and breathe through their nose, because that's going to help their whole life. If it doesn't help enough to control the sleep apnea, then you can go on to something else. But some have been able to reverse it.
Okay. Just a quick point on that. A comment here in the chat said that she was diagnosed with apnea and enjoying freedom from my CPAP and restful sleep with frenum release and orofacial myofunctional therapy. Also closed my interior open bite with no ortho.
Wow, that's fantastic. Well done. Yeah, so release the frenum, get the myofunctional exercises, get that tongue back up to the roof of the mouth. And it is amazing that's amazing that she was able to close her open bite too, because muscles trump bone every time. So if you can get your lips pulling closed, you can actually impact the teeth. So well done. That's good.
Yeah, that's really wonderful. The last thing I'd like to ask you, Tricia, is a lot of people are saying great handouts, wonderful slides. Are these available to our attendees by any chance?
I haven't put that together, but I could if they wanted that. If I could, let me type in here where to go. If they go to onlineoralhealth.com tomorrow and look under handouts, look under secrets and then handouts.
Okay. Wonderful.
First and then handouts, I will put one out there that will be these slides.
Great. A lot of the attendees were saying what great slides they were and how helpful they may be in their offices and for patient education. So,
and if they want to, if they go to lipzipbook.net, there's a free little book there about the boy who snored and the goose that honked, and also an option to information about an online course if other people in the office want to learn more.
Wonderful. Well, if there are no more questions, we'll go ahead and let everyone go on with their night. You've got the CE code 6160. Shortly, you'll be directed to the attendee lounge, where we ask that you please complete the course evaluation and where you can enter your CE code into your record. Enjoy your evening and hopefully see you tomorrow.
Thanks, everyone. It was a pleasure.
Is this also called Mewing? MEWING.
Mewing, MEWING. That's named for John Mew. Mew is the orthodontist in the UK. I showed a few cases from. John also has a son, and his son has put some things out on YouTube, and now they named it after him, and some of these exercises are called mewing. So, yes. So, good question. You guys are very on the ball with this information.
All right. What did you guys think? Did you